Hello doctors, today we are here with another very important topic of general surgery, that is surgical nutrition. So surgical nutrition means either we give the patients food via the oral cavity like normally we eat, or via the nasogastric tube, nasoduodenal tube or nasojejunal tube, or via the feeding jejunostomy or feeding gastrostomy. This is known as enteral nutrition, means giving the food from the mouth or directly into the alimentary canal. And parental nutrition means giving the nutrition from the IV line, either peripheral IV line or central line. Most commonly we give via central line. And in parental nutrition we use the TPN. This is total parental nutrition. The TPN packets look like that, you have seen in your wards. So starting with the nutritional assessment, no single reliable biochemical marker for malnutrition is present. There are multiple factors which contributes to the malnutrition. So we can detect it via low albumin level, which is an indicator of poor nutrition, or very importantly remember, unintentional weight loss. Means when the weight loss is more than 10% in 6 months without any intention, when there is unintentional weight loss. And we also measure it via skin fold thickness, an indicator of muscle fat, and mid-arm circumference, which is an indicator of muscle mass. And what are some of the scoring system? You have to just remember the components of them. First is the NUDEC scoring system, which have age. We consider age, Apache 2 score, SOFA, number of comorbidities that patient have, and the days from the hospital admission to the ICU admit. These are the components of NUDEC score, that is age, Apache score, SOFA, number of comorbidities, days from the hospital admission to ICU admit. If the score is 0 to 4, it is known as low malnutrition risk. If the score is 5 to 9, it is known as high malnutrition risk. And this patient need nutritional plan. We have another score which is known as PONS, that is perioperative nutritional screen. The criteria is that when the BMI is less than 18.5 and there is unintentional weight loss, means when the weight loss is more than 10% in 6 months, and the diet that patient takes normally, now he is taking 50% of the normal diet, then these patients need pre-operative nutritional consent. Before any operation, we need to send these patients to a nutrition consult. And we have third score, that is MUST score. MUST is Malnutrition Universal Screen Tool. Here also we take account BMI score, weight loss score, acute disease effect score. If the score is 0, then it is a low risk. If the score is 1, then it is a medium risk. If the score is 2 or more, it is known as high risk. So this is the MUST score, Malnutrition Universal Screen Score. So we have seen 3 scoring system. One is NUDEC scoring system, another is PONS, another is MUST. There are 3 scoring system here. Now we will see about the enteral nutrition. Enteral nutrition means we are giving the food directly into the alimentary canal or via the mouth. Why the enteral nutrition is better? Always enteral nutrition is better than the parenteral nutrition. Why? Because it is physiological. Normally how we eat, it is similar to that. It is cheaper and it prevents translocation of gut bacteria. Means the gut bacteria will stay in the bowel only. It will not go somewhere else. The routes are the oral route is the best route. If the requirement is less than 3 weeks, then we can put the tubes. Like if patient have good gastric emptying, then we will put a Ryles tube, that is nasogastric tube. If the patient have poor gastric emptying, then we will put a nasojejunal tube. From the nose directly up to the jejunum, we will put the tube. If the requirement is for less than 3 weeks. And if the requirement is more than 3 weeks and patient have good gastric emptying, then we will do feeding gastrostomy. And if the patient have poor gastric emptying, then we will do a feeding jejunostomy. This is the criteria of doing a feeding gastrostomy and jejunostomy. So first, this is a Ryles tube. This is how a Ryles tube look like. To check the correct insertion of a Ryles tube, either you aspirate it, there will be gastric content present when you aspirate it, or you can push the air and listen to the stethoscope or feel it in the stomach. How to measure the Ryles tube? How much length you have to insert? Starting from the nose, you have to measure up to the earlobe, then earlobe up to the xiphisternum. Place the tip of the nasogastric tube at the tip of the nose, then measure from the nose to the earlobe and down to the tip of the xiphisternum. This is how we measure the length of the Ryles tube that is to be inserted. So this is the Ryles tube. This is the nasogastric tube. Up to the stomach we have inserted it. Therefore, this is a nasogastric tube. And here we can see it is inserted up to the jejunum. So this is a nasojejunal feeding tube. And if you insert up to the stomach, then it will be a nasogastric feeding tube. Now tube feeding. The rate of feeding, when we will start with 10 to 20 ml every hour or 50 ml every 2 hourly. We will start the tube feeding, and we can increase to 75 ml per hour if the patient is tolerating well. We will gradually increase that. Now we will read about the feeding jejunostomy and feeding gastrostomy. Feeding jejunostomy, we can do two techniques. Either we have the STAM technique to do a feeding jejunostomy, or we have the Witzel technique. STAM technique means we will give, this is the jejunum, we will give a stab incision inside the jejunum. And when we give a stab incision, we will put Ryles tube from this, and we will tie this via a purse string suture. This is known as STAM technique. A stab incision is tied, and then the Ryles tube is tied via the purse string suture. But what is the disadvantage of this STAM technique? The disadvantage is that there is increased rate of peri-drain leakage. There will be increased rate of peri-drain leakage. From where you have given the stab, from here there may be leakage present. Therefore, this is a disadvantage of STAM technique. Now we have the Witzel technique. This is the Witzel technique. Witzel technique is a tunnel is created further. This is a tunnel, you can see a tunnel is created further, and it has a less rate of displacement and less peri-drain leakage is present in Witzel technique. So there are two techniques for feeding jejunostomy to make, that is STAM technique and Witzel technique. Now feeding gastrostomy. Feeding gastrostomy can also be done via a STAM technique or Witzel technique, as we have seen in feeding jejunostomy. And another method is that is PEG. PEG is percutaneous endoscopic gastrostomy. PEG is endoscopic placement of the tube inside the stomach. We will put an endoscope from the mouth passing to the esophagus inside the stomach. Then there are three techniques present, either push technique or pull technique or introducer method. These are the three techniques for doing a percutaneous endoscopic gastrostomy. So via the endoscope from the mouth, we have put it inside the esophagus, then inside the stomach. Then from here, we will put the PEG gastrostomy tube. This is the PEG gastrostomy tube. We have put it inside, and then we can start the feeding from this tube. We have another technique, that is RIG. RIG is radiologically inserted gastrostomy. When we do RIG when we cannot put an endoscope in the esophagus or in the mouth, like people have pharyngeal carcinoma, or if the person have esophageal carcinoma obstructing the lumen and you cannot put an endoscope inside, then radiologically we can do a gastrostomy. Indications are for doing RIG is when the esophageal intubation is not possible, compromised respiratory function is present in the patient, and compromised oropharyngeal anatomy is there. Then we do a radiologically, like radiologically via the fluoroscopy and all. We radiologically directly put inside the gastrostomy tube inside the stomach, and we fill this balloon with the water. So this is the RIG technique. And what are the complications? We have seen the advantage and techniques. Now what are the complications of enteral nutrition? The complication, one is tube related complication. Tube can be blocked or migration of the tube may be present. And feeding technique will be osmotic diarrhea may be present, overfeeding syndrome, refeeding syndrome, and even aspiration may be present in enteral nutrition. Now we will read about the parental nutrition. Parental nutrition means giving the nutrition from an IV line, either central line or peripheral line. So when will you give the parental nutrition? When there is a prolonged paralytic ileus for more than 72 hours. When there is a short bowel syndrome. SBS is short bowel syndrome. The length of small intestine is less than 200. That is known as short bowel syndrome. Or in cases of high output fecal fistula. High output fecal fistula means when the fistula output is more than 500 cc in 24 hours. That is known as high output fecal fistula. And low output fecal fistula is when the output is less than 200 cc in 24 hours. If the patient have an inflammatory bowel disease, Crohn's disease or ulcerative colitis, and the initial phases of acute severe pancreatitis. So parental nutrition should be started in patients of prolonged paralytic ileus for more than 72 hours, in cases of short bowel syndrome, in cases of high output fecal fistula, in cases of acute episodes of IBD, and initial phases of acute severe pancreatitis. Now, what are the routes of parenteral nutrition? We generally use the central line. This is the best route to give the parenteral nutrition. Now, we can put central line either in the subclavian vein or in the internal jugular vein or in the femoral vein. Most commonly used central line for TPN is IJV, internal jugular vein. Now, we have to see some of the complications and advantages and disadvantages of this. First, subclavian vein. Subclavian vein, if we put a central line in the subclavian vein, there is a least chances of thrombosis and infection. And maximum chances of thrombosis and infection is present in the femoral vein. Therefore, it is avoided. If we see the risk of pneumothorax, the pneumothorax risk is maximum in subclavian vein. And ease of insertion, the most easy to insert a central line is IJV. And therefore, more commonly, IJV is used in emergency purposes. Remember this, least chances of thrombosis and infection is present in subclavian vein, and risk of pneumothorax is more in subclavian vein. But ease of insertion of central line is best in IJV. Therefore, in emergency also we put an IJV central line. Now, after putting a central line, always send the patient for X-ray or do a bedside X-ray, and you have to see the tip of the central line. It is asked many times in MCQ. Keep it in your mind. The tip of the central line should be just above the right atrium. It should not cross the right atrium. It should be just above the right atrium. Sometimes if the central line is put in deep enough, crossing the right atrium into the right ventricle, their patient might have arrhythmia. So, therefore, to see the tip of the central line is very important. Now, PICC line. What is PICC line? PICC is peripherally inserted central line. When we insert the central line peripherally, like this in this diagram, you can see this is the central line, but we have put the central line in peripheral veins. Now, PICC line is inserted, peripheral IV line, and tip lies same as that of the level of the central line. Can be maintained for 3 to 4 months. We can keep that for 3 to 4 months. And when we do a PICC line, the patient who have declined for chemoport insertion or requiring a long-term antibiotic therapy, then we can put a PICC line, as you can see in this picture. Now we will see some of the points about the TPN. First, you have to remember the TPN have the ratio of 20:30:50, like 20% of protein, 30% of fat, and 50% of carbohydrate. This is the ratio of TPN. If the patient have respiratory failure, then we have to give the parenteral nutrition with having low carbohydrate and low volume solution. And if the patient is having renal failure, then also we have to give the patient in low quantity, but high carbohydrate and low protein solution should be given in the patients with renal failure. Now, monitoring of the patient on feeding regimen. If a patient is on feeding regimen, the earliest sign of overfeeding is weight gain. How much? That is more than 1 kg per day. If the patient's weight is increasing more than 1 kg every single day, then you have to suspect overfeeding syndrome. And second most common is rapidly increasing in abdominal girth. If the abdominal girth of the patient is rapidly increasing, then also you have to suspect the overfeeding syndrome. Daily you have to monitor. In these patients, you have to monitor pulse rate, blood pressure, temperature, body weight, fluid balance, urine output, stoma output, and the type of food consumed. If the patient is eating also, then type of food consumed is also important. And you have to also check daily the sodium, potassium, urea, create, blood sugar level, magnesium and phosphate. If the patient have refeeding syndrome, then you have to send liver function test and C-reactive protein. These are the plasma levels that you have to send every day. But remember this, these tests are shifted to weekly basis if the patient is stable. If the patient is unstable, you have to send these tests every day. When the patient is stable, you have to send these tests just weekly. And from starting, you have to weekly send the CBC along with total leukocyte count, serum calcium, zinc, copper, serum albumin, thiamine, lipid profile, vitamin B12 and folic acid. This test should be sent weekly. And 3 to 6 monthly, you have to test for ferritin, selenium, manganese, 25 hydroxy, vitamin D. These are the tests that you have to do daily. These are the tests that you have to do weekly. And these are the tests that you have to do 3 to 6 monthly in a patient who is getting a parental nutrition. Now, what are the complications of TPN? One is central line related complication, that is pneumothorax, arrhythmias, thrombosis, air embolism, and migration of central line may be present. And most common complication of central line is catheter related sepsis. Catheter related sepsis, the patient will present to you with rigor, with fever, and in these cases you will remove the central line and cut the tip of the central line and send the tip of the central line for culture. Like, you have to send the tip of the central line for culture, and you have to send blood culture also, and swab from the central line using endoluminal brush if you are suspecting a catheter related sepsis. Feeding regimen related complications are hyperglycemia most commonly, then weight gain, cholestasis. Remember, in prolonged use of TPN, there will be cholestasis and patient may present to you with jaundice. If a patient presents to you with jaundice and having a prolonged TPN use, then stop the TPN immediately. And micronutrient deficiency may also be present, most commonly zinc deficiency, remember this. And patient might also have refeeding syndrome. So these are the complications of TPN. One is central line related complication, another one is feeding regimen related complication. Now, refeeding syndrome, very important topic. 1 to 2 questions are asked in every exam, whether it is a NEET PG or NEET SS exam. So refeeding syndrome is when large quantity of nutrition is given to a chronically malnourished patient. When we give a large quantity of nutrition, then there will be refeeding syndrome. And what are the abnormalities that is seen in refeeding syndrome? That is hypokalemia, hypomagnesemia, hypophosphatemia, hypocalcemia. And out of which most common and main driving force for metabolic derangement is the hypophosphatemia. So remember, these are the abnormalities in the refeeding syndrome. Very important topic. When will you suspect a patient will have refeeding syndrome? So there are criteria, either one or more of these 4 features or 2 or more of these 4 features. One or more of, like if the BMI is less than 16 kilogram per meter square, unintentional weight loss for more than 15% within last 3 to 6 months, little or no nutritional intake for more than 10 days, low potassium, phosphate, manganese level prior to feeding. If any one criteria of this present, then you will consider for a refeeding syndrome. 2 or more criteria of these, like if the BMI is less than 18.5, unintentional weight loss for more than 10 kg in last 3 to 6 months, little or no nutrition for more than 5 days, and history of alcohol abuse or on medication including insulin, chemotherapy, antacid or diuretic. In these patients, out of this criteria, if any 2 criteria is present, then the patient will have a risk of developing refeeding syndrome. So remember this important topic. And how will you manage the refeeding syndrome? Start with maximum 10 kilocalorie per kg per day, aiming to increase to full need by 4 to 7 days. Gradually, we will increase the nutritional need. And how will you prevent refeeding syndrome? Gradually, first I have told you, gradually increase the quantity of the feeds, strict monitoring of the electrolyte, and thiamine supplementation is important. In this way, you can prevent the refeeding syndrome. So refeeding syndrome is a very important topic for your exam purpose. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you, guys.